Welcome, everyone. I'm Cinda Rushton. I'm the co-chair of the Johns Hopkins Hospital Ethics Committee Consultation Service, and I want to welcome you to our December Ethics for Lunch. We have an incredible panel that is going to help us explore the intersection between ethical practice and spirituality, and how those concepts align as we try to work with patients and families and our colleagues around tough ethical questions. And I am going to introduce Ty Crow, who is our Director of Spiritual Care and Chaplaincy here in Johns Hopkins Hospital, and who has been a steady and steadfast member of our ethics committee for a number of years, to introduce our panel. So, Ty?
Thank you, Cinda. Welcome. Happy holidays to those of you celebrating this month. It's exciting to be a part of spiritual care in December for Ethics Month. So what I want to do to start, everybody here okay in the back? Is to give you a little bit of a framework for spiritual care and how we're set up in the hospital. I'll give you a little bit of data before we jump into the case and with our panel. So the way we're set up, we're set up to do a 24/7 on-call service. I think most of you probably know that, but it's worth saying that we do everything within a 10-minute response. We have 6.5 FTEs in the department. That does not include the majority of our students. All of our staff chaplains are board certified by the Association of Professional Chaplains. That's an important component, or the National Association of Jewish Chaplains, as is the case. That's also true from JHH and at Bayview. Most clinical areas and certainly all of our ICUs are covered by an assigned chaplain, and all of our chaplains function in an interfaith capacity. That's a little bit of a variance from what you may experience normally from clergy, who are operating within their own faith structure. Here in the hospital, you'd be operating out of the structure of someone else's faith. It's a little bit of a different calling. Two exceptions to that is we have a Catholic priest that's assigned to us by the Archdiocese of Baltimore. We have a part-time rabbi who is here. Obviously, they're visiting the Catholic and Jewish patients respectively. 50% of the patients, maybe 50%, a little bit above, are done by student chaplains, and our training program, which is embedded within our department, is nationally certified. It's called Clinical Pastoral Education. Some of our staff chaplains, you may recognize some of these names. We have an oncology chaplain, Reverend Rhonda Cooper, pediatric chaplain, Matt Norvell, family advocate chaplain coordinator, John Panala. Both Matt and John are on our ethics committee. Yay. Catholic priest, Father Samuel Uzukwu, and our part-time rabbi, Rabbi Steve Short, who's in the audience, I can see. And Director of CPE and Community Chaplaincy, Chris Brown, who is also part of our panel. We have two chaplain fellows, also part of our department, Susan and Kat. Susan is focused in palliative care, obviously focused on patients that are assigned to that palliative care service, but also she's doing care for the caregiver, which is a weekly support group for fellows in palliative care, rotating palliative care, and looking at decreasing the burnout in that group. Kat is also doing unique ministry, sometimes visiting parents before they give birth during a difficult medical experience. And this is also new in the NICU. We feel like we're paving new ways for chaplains here. As I mentioned, our training program, nationally certified. Basically back in 2013, we joined forces with Johns Hopkins Bayview. We said we didn't need to compete for students, and so now we don't. We're one of 5 training centers in Maryland. We're the only one in Baltimore, and we put through about 50, 55 students through our training program each year. We offer 3 different levels of training. You can be a part-time student, and you'd be with us for about 6 months. You can be a full-time resident, and be with us for a year, or you can be a supervisory education student, sometimes with us for 3 to 4 years. All right, here's some stats real quick. So we do about 400 plus supportive staff conversations per month. That includes both routine and acute It could be someone that you know in the hallway that you're stopping by and you're having a quick 3 or 4 minute conversation. We do about 1,500 plus patient encounters each month. That's a little bit less than 20,000 visits here at JHH every year. The MICU is probably not a surprise, is our highest generator of referrals. We do about 80 plus per month. And Epic, God bless Epic, doubled our daily referrals since July. It's easier to hit that button. All right, so we did a survey also within the Department of Medicine for the last 2 years. We had almost 250 surveys collected. And I just want to give you a quick snapshot of some of the highlights here. So who are our patients at JHH? Among spiritual and religious values influence all aspects of my life, 28% strongly agree, 53% agree. That gives you a quick snapshot of how religious and spiritual our patients are. Felt offended that the chaplain visited, 75% strongly disagree, 19.2% disagree. Viewed chaplain as part of the overall medical care team. 33% strongly agree, 54.3% agree. The most helpful aspects of the chaplain visit seem to care about me. Number 1. Close number 2 sat down to talk with me. Actually, number 3 is listened to me. And number 4 is prayed with me. You may have thought those would have been all reversed, right? Chaplain should show up only when a patient is dying. 84.8% strongly disagree. 8.7% also disagree. The chaplain helped me accept my medical reality. 38% strongly agree, 38.6% agree. And the chaplain's visit positively influenced my overall rating of the care provided by the hospital. Again, we have 33% and 48% agree. Again, just a snapshot of what some of our patients are saying about their experience being visited by a chaplain. So we also conducted, I think this is also helpful, is just really quick, we did a survey for internal medicine residents and asked them, what are your barriers for talking about spirituality with your patients? And these are listed in order as they rated them. Number 1, time. The assumption that this is going to take a long time if I open up this conversation. Number 2, difficulty identifying whether a patient desires a discussion about their spiritual issues. Number 3, not sure about the language. I don't know if I have the language or how to even begin that conversation. Number 4, concern about lack of concordance between my patient and my own beliefs. What happens if we're not really in sync here? And similarly, as number 5, an actual fear that introducing spirituality will open a patient's questions to me and my own spirituality as a physician. So, I'm really excited to introduce our panel. I think we're going to generate some good discussion from this case that we brought. Rob Rozick, Assistant Professor, Johns Hopkins School of Medicine. Thank you, Rob. Lynn Billing, a nurse clinician, oncology here at the hospital. Chris Brown, newly appointed CV and Community Chaplaincy Director for our hospital and health system. Jane Hill, Director of Patient Relations and Family-Centered Care here at our hospital. And Allison Turnbull, Assistant Professor, Department of Pulmonary and Critical Care Medicine here at the School of Medicine. Thank you all very much for being here. So, I was encouraged to read the case. I'm going to put it up here. You can read along with me. So our case here is a 65-year-old woman diagnosed with colon cancer and treated with several rounds of chemotherapy before undergoing a hemicolectomy. She subsequently was hospitalized for 6+ weeks following surgery due to complications. She became demoralized about her health outlook, and a chaplain was referred to see her. Although she was not religiously affiliated, she had been raised in a Christian setting and was appreciative of the ongoing support of the chaplain, who normalized her feelings of discouragement, provided a sounding board as she struggled to find meaning in the midst of suffering. She was discharged home. 6 months later, the patient was readmitted to the hospital with cachexia and fatigue. Her diagnosis was liver metastasis, whereupon she was presented with a plan that included additional chemo. She sought spiritual and emotional support again from the chaplain. She desired palliative rather than aggressive treatment and requested that the chaplain be contacted to serve as her witness to this decision. She said she had made peace with God and did not want to be a burden anymore on her husband. The patient's husband and the medical team did not agree with her decision. They felt that targeted treatment held promise to extend her life for several months. The patient refused. So the team requested an evaluation by psychiatry to be sure her decision was not clouded by depression. Psychiatric consultants deemed her to have capacity to make her own decisions. Psychiatric evaluation and her husband's disapproval or fear of a more palliative approach led her again to feel demoralized. The patient reluctantly acquiesced to the team's recommendations and began another round of treatment. She told the chaplain that she was not being heard by either her husband or her medical care team, and that she would just, quote, go along with what they wanted for her. At this point, I'll turn it over to our panel, who are going to take time to respond from their notes and from their thoughts on this case.
Do you want to draw straws?
Good afternoon, everyone. You know, I'd like to start a conversation with the term patient and family-centered care. I think sometimes people think that is a new term. It is the newest buzzword. It is the newest, let's jump on this bandwagon. But I'm going to go back a few centuries to Hippocrates, who says, cure sometimes, heal often, and comfort always. And then if I move up a few centuries to Sir William Osler, who's very important to this organization, he talks a lot about relieving suffering as a major part of a physician's role, and I will extend that to a clinical team role and actually the clinical support team, including pastoral care. And then I would take it up one more to a writer that you all may have heard of in the last year. His book is called When Breath Becomes Air, which is a profoundly beautiful and sad book where the author, who passed away, wrote, and he was a physician in training, he wrote, the physician's duty is not to stave off death or return patients to their old lives, but to take into our arms a patient and family whose lives have disintegrated and work until they can stand back up and face and make sense of their own existence. So, you know, all those powerful terms really talk about what the role is here when we can help people, which include the patient and their families during these very, very tragic times. And it is so hard for the family when a patient may have been going through these stages with the help of pastoral care and other members. But our own medical teams, I think, sometimes forget that it is very hard for them to think that a miracle is what they have to do all the time. And I feel they need support to know that they are not always expected to pull off a miracle. And so I just want to just share that as a way of helping our clinicians who sometimes feel an expectation and obligation, especially for patients who come to Johns Hopkins. They are looking for a miracle sometimes and maybe the miracle is not what as they expected, but it's a different kind of miracle, which is really having a peaceful transition.
This is truly a complicated case, and we have in front of us a human dilemma, because on on one hand, you have a woman who is in the midst of her own suffering, and it seems that she's ready to say goodbye. And on the other hand, you have a husband who truly loves his wife, and it's difficult for to say goodbye. And then you have, okay, the patient care team, who is here to take care of the patient, who's there to take care of, and all, but in this situation you have, that it seems that no one wants to have a conversation about how it feels, because in chaplaincy we deal with feelings all the time, about how difficult it is to talk about death. No one wants to talk about death. And I want to just hold my colleagues out there. How many of you all, it is your job to talk about death? It's in your job description. Those of you all, please stand. I just want to recognize those to see. Please stand, those. This is what we do every day. Okay, thank you. Now, those of us who it is not your job to talk about death, will you all please stand? That is a huge difference, don't you see? So you're dealing in this situation, you have who is the patient, who is totally, has come to the point in her life that she's ready to say goodbye. And also to say, and to the chaplain, because you hear, she's called the chaplain and said, okay, I want to talk about this, I'm ready to let go, I can't take on this treatment any longer. The chaplain joins her. However, then the husband is saying, I don't agree with that. And it seems like the patient care team as well. So they call psychiatrists to evaluate her. So imagine if you was in her shoes. It's like, there's such a power differentiation in there. It's like, I got the chaplain and just I and the patient care team. It's like, okay, you know, and I've learned in my process, and we talk about this today, about it's hard to confront in situations like this, and I've always used, with Richard Lawson has helped me to use this technique called carefrontation. Because when you confront someone about when they're trying to let go, sometimes it's called, there's shame, there's a lot of shame in there. And it's like you have to have some finesse and how to navigate through all of these systems to say, you know, the person is not giving up. It's not that we are letting go, especially as Ty talked about language. We are quick to say withdraw care. We do not withdraw care. We withdraw treatment. The care never stops. So it's all about how we engage the different dimensions of this encounter so that the patient can be heard. You talk about patient-centered, family-centered, that the patient can be heard. And that's one thing that we do on the team, that we join with palliative care. Palliative care and chaplaincy seem to have this marriage that we have, that we can go into those ways, those days and those ways and those vortex where we don't want to talk about the end of life issues, but we can talk about that. But there's other disciplines and specialties and coaches on the patient care team that really struggle with that. And if you're struggling with that, I invite you to be aware of that, because that may be preventing the patient from feeling that I'm being demoralized, I'm not being heard.
So a couple of things that really jump out at me. Clearly suffering. There's a lot of suffering here. Not only for the patient, so the patient is clearly suffering from her illness. But I think one thing I see here is the care team, treatment team is suffering. Because quite often what happens is we feel like we always need to do something to people. And Brené Brown says it best in her book, Rising Strong. When she talks about suffering, she says, what happens is when we don't make judgment on people, is we see people suffer through difficult times. And suffering can come out in different ways. So some of that could be offering treatments that may not be helpful, offering things that can sometimes be harmful, but this is what they know. They know what to do, and they don't know what not to do. And I think many of our jobs needs to be not only to take care of our patients, but also take care of our colleagues and help direct them through conversation. So one thing, my experience with this was there was a patient who was in our cancer center who had CNS lymphoma. And we have one of the world premier docs taking care of this patient. And we went into a family meeting, and he had a difficult time having these conversations about goals of care. So the following meeting, I sat with him in advance and I asked him, it sounds like you give chemotherapy to prolong life, to reduce tumor burden so they have better symptom control. He said, and I said, is that achievable in this patient? And he said, no. And I asked him if he would share that with the family member, and he did. And what happened is she broke down. And right after that, she said, but doctor, can't you please do something? And that's when he backtracked on some of his work. And he was clearly suffering. And he said, well, let me talk to some of my colleagues, see what else can be offered. Here's the world expert. And this was him suffering and sort of offering treatments that may not have been available or that could be harmful. And so what I had to do is jump in and ask him some direct questions. Could this therapy harm you? Could this therapy harm him? And he said yes. And I said, could it shorten his life expectancy? Certainly. And his wife heard that. And she listened and she realized what other options there were. And after the family meeting, I emailed him and said, thank you so much for being honest with his wife. She really needed to hear that. And his response was, thank you so much for redirecting that conversation. Because he was clearly suffering. And similarly, the husband here is suffering because he doesn't know what else to do. And that's where spirituality, that's where palliative care, that's where social work comes in to really take part in this truly interdisciplinary work that needs to be done.
So I come from palliative care world, mainly in oncology, and this case is very complicated, but it's pretty common too. See this a lot. This patient came in and she's devastated in a number of ways. She is suffering. She's exhausted. She's fatigued, and she doesn't have a voice. The team is saying one thing, and the patient is trying to say something else, but she's not being heard. She doesn't have the energy. That's where chaplains come in, and that's where, a lot of our role as a palliative care clinician kind of overlaps. Is we do listen. We have the time to sit down and listen. And I think part of the other thing that we do is empower the patient. We can help give them a voice by, first of all, listening to them and validating what their concerns are, what their sorrows are, what their issues are. A lot of times I hear medical teams say, they just don't get it. They just don't get it. Can you go in there and help them get it? Well, who's not getting it? That's the question. Often it's the patient and the family understand what's going on, but the team isn't hearing them and what their concerns are. And we often hear from patients and families, God is in charge. It's in God's hands. And what we need to do when that happens is not to fight that. And my chaplain friend, Rhonda, taught me something very smart. When we talk to patients about chemotherapy, when we talk about treatments, when we talk about what they understand, we want to join them and say, yes, we're hoping for those things too. And then the next word is very important, but. That negates everything I just said. So the right word to say is and. So this is what's going on, and I'm your nurse here today. I can talk to you about a lot of different things. I can provide you some information and really help you do what you want to do. you don't want it to be an us against them thing, and that's what these kinds of situations often turn out to be. And we want to join, and that's the only way that we're going to work together as a team with the patient and the family.
So I'm Allison, and just to clarify what I'm doing up here, I'm a researcher, and most of my research happens in the medical ICU, which has a lot of referrals to chaplaincy. The first thing I would clarify about this case is that I think we've heard about patients deciding to stop chemo or to stop treatment. Just to clarify that an adult patient with capacity to make treatment decisions can refuse lots of treatments, including life-sustaining treatments. So often in the NICU, that's patients even saying no to life support, or I want to come off the ventilator, even though that means I'm going to die. So this extends beyond just chemo, but I want to make sure that's clear. We've talked a bunch about what the patient is feeling and about this demoralization. And I think the two things that stand out to me that I am going to, I would presume is happening for this patient that are really spiritually damaging are loneliness and isolation and judgment. So not only is she, I'm sure she's not physically alone, probably almost ever, but psychologically she knows that nobody sees her life like she's seeing it right now. She is alone in that. And that has got to be really hard. And while I absolutely understand the necessity of ensuring that she has capacity to make these decisions, I suspect that the psych evaluation further reinforced that we have such a hard time imagining the decision you've made, that one of the possibilities is that you have mental illness. That's how hard it is for us to believe you. And that's very isolating. The second is shame, because the language we tend to use around these decisions, she's giving up, she doesn't want to fight anymore, or she doesn't get it. The implicit, value judgments are there in that are either she's not smart or she's lazy, she doesn't want to go through it again. And if you feel alone and feel judged, you need chaplaincy. That's exactly where they come in. Because often their statement is, you're not alone, I'm sitting with you and I'm listening, and I'm not here to judge. I'm here to listen about how you've come to this decision. So I think that's essential to recognize that need. That's a very real spiritual treatment need that the patient has right now that chaplaincy can fill. And then we've talked a little bit about the husband, and I want to go back to that again. There's increasingly there is data that shows that the family members of critically ill patients in the ICU are at greatly increased risk of negative mental health outcomes, including complicated bereavement and depression and anxiety and even symptoms of PTSD. And looking at this, I kind of think this patient has done a lot of spiritual work. She has, quote unquote, made peace with God, and she has talked to a chaplain a number of times. She has thought hard about her own mortality. She's done a bunch of work, and I'm concerned that maybe her husband has not. And he may be at pretty big risk, whether she dies very soon or in more months after chemo. He's going to be at risk if he isn't helped and protected in some way and assisted through the spiritual work he's going to need to do to become a widower. So I see a need for chaplaincy there as well.
I just want to add, in patient relations, we typically have about 100 open cases per day of people around the hospital, patients, families, sometimes friends of family, or caregivers who aren't family in a legal sense, but are certainly family in a spiritual sense. And so I'm not sure if the group here knows that of these 100 open cases a day, so these are typically not about the temperature of the food or someone looked at me cross-eyed. I mean, those do appear sometimes, but they're actually quite complex and complicated issues that typically revolve around listening and communication. And so one of the things I do want to share is we also get letters of appreciation and gratitude. And most of these are from family members whose loved ones have passed away here. And it is like a gift when we get these. And we learn every time we get a letter of gratitude. And these letters are really about, and often it involves the team, including our spiritual team, to help families forgive themselves for coming to terms with the fact that the patient passed away, died. And they feel that they were allowed permission not to quit, but to let go. And there is a real difference between what that means to them, and this goes back to what Allison said about helping them recover from a tragedy. And I just want to share that when we get these letters of gratitude, they are remarkable. And they are remarkable because they are so generous in thanking us for this tragedy that befell them.
Well, thank you, panel. So I think at this point, we'd like to spend the remainder part of our time having a more fruitful discussion, taking some of your questions for the panel, and let's take this case even further. So Peter's got a mic, just raise your hand.
Thank you very much, panel, and time. I'm interested in having more of a discussion of what it means to be having made peace with God. You would discuss it, or chaplains would discuss what that means, and when you go into a room, if you want to know whether a person, you use the term, having made peace with God.
Well, for me, I can't speak for others. However, in chaplaincy, that is a difficult question. Have I made peace with God? Because I don't know what your God may look like. I don't know what even peace means for you. So what I always would invite when I hear that questions, when I hear that claim, I always want to flesh it out, to explore what does that mean for you, making that peace. What is God to you? Because God can be interpreted in many ways differently. So it's like that will put their own personal meaning of how they feel with God. And also, as we talk about language is quite powerful for me. There are moments when some words may stir up certain things. I'm really sometimes perplexed by, challenged by the word, their transition. Have you ever heard of that? Someone has transitioned. Or, even the word passing is getting more comfortable with the word death. That's very difficult because it brings an awareness of what's happening. Because there are times when you have patients, there are families, even the patient care team is quite aware of or unconscious of what's happening. I believe there's a lot of unconsciousness that's happening in this encounter that we're exploring, like what's happening. Because you can truly see that in this case, you have a patient as well as a chaplain. They're talking about it, but it's the other members of the team that's struggling with that. So hopefully that will bring some clarification or some response to your question.
I think the piece that I would add to that would be the spiritual work that I think Allison had indicated. These things aren't arrived at oftentimes overnight. It's conversation within oneself and within one's sense of the holy. And sometimes it's in the framework of a faith tradition, and sometimes it's not. Sometimes the language, as Chris indicated, is sort of, oh, we all understand what that means. But we have to be careful with that, and I think it's worth a follow-up conversation, or at least a question. What exactly do you mean by that? In this case, it's coupled, right? It's coupled with peace with God, and I don't want to be a burden. So these two coupled together are leading this patient in the case to seek out more palliative treatments. And the idea of being a burden, or at least releasing the burden on my spouse, is also probably related to her sense of peace. So we don't always know. I think it's worth, having a more in-depth conversation about it. But as patients share that with us as providers, I think that it's important to pause. It's important to pause and to take it in. What do you really mean?
In Judaism, you really don't have to make peace with God in a sense. But in many cases I dealt with over the years is where there's a fear of an unknown. And I'm going to be punished because of sins that I've committed. And in those cases, I come in and I have to say, listen, God is understanding, God's forgiving. I had a doctor one time who was dying, unfortunately, with leukemia, and told me, he asked me to forgive me for having an affair with my neighbor. So I said, listen, the fact that you say right now that you tell me the story means he showed regret for it. And God is understanding and he is forgiving. So I give them that encouragement that when they come out, they have nothing to fear. Because God is loving and God is understanding. So again, I don't think there has to be that peace with God. There has to be peace within yourself. That you have to understand that where you're going, it'll be a better place, and a place where God will understand you.
So I had a question that was sort of based on one of the discussion questions you had here, which is, I saw number 2 was framed as, what roles do chaplains play in supporting patients' medical decisions? And at the end of the case narrative, I was really interested by the position the chaplain would be in, whether the chaplain sees his or her role as supporting what looks like an announced decision, or sort of raising questions about, or pushing back against, or helping somebody think about alternatives to decisions that it looks like they're making. Maybe a way of framing this is whether people think about the role of chaplaincy as being sort of purely non-directive support, or to what extent something other than support can make sense as a model for thinking about patient medical decisions.
You unloaded a lot on me, so I'm trying to flush it out. Well, it depends on and I want us to look at also the culture, because it depends on how the role is being perceived by the patient, by the family, and even the patient care team. Like I said before, I've worked with several different specialties where they really embrace chaplaincy and encourage, for the invitation for a chaplain to come and visit. There are other cultures and discipline, even from units here, that's like, oh, I really, because the chaplain represents death. And there are times when we are there, not just in the down moments, but in the up moments of being celebrating as well. Is that we are there to support a journey with the patient and the family as they go through that crisis, not to solve anything, or to solve the problem. We are there to provide that emotional and spiritual support. Also to be there to advocate for the patient. Too, because there are moments when the patient feels that the chaplain, that's someone I can feel safe with, that can contain my grief. They're comfortable. We're talking about death and dying. I can share confidential information with them that I may not be ready to explore or even to share with my other family members, or even with the patient care team. So we have a role on the patient care team that really is embraced and really feel that that role is important. They will be able to hear us, because we are the voice of the patient and family on those patient care rounds, in those meetings. And that's what's being portrayed to me in this case, that the patient and the chaplain, they're connected. She's the sojourner of that patient with her, right beside her, but it seems like there's some issues, with the patient care teams not quite seeing the dynamics or even hearing. And I appreciate my colleague lifting up the role of, because it's difficult for the chaplain, because you're caring for not just the patient, but their family, as well as the staff support. So we got a lot of people that we have to care for, but we have to be non-anxious and very non-judgmental, and to be there for everyone on the team. But it's all about how your role is being, accepted or being perceived by the patient as well as the patient care team.
If I could just follow up on so at the end where she says she would just go along with what they wanted for her, I'm really interested in sort of what the first response might be from a chaplaincy service. I can imagine a variety of ways somebody might respond to that in conversation.
Well, as a human being, imagine this woman being in this situation. I share with the chaplain, I share with my husband, I share with the patient care team that, I'm suffering, I'm ready to not do this other round of chemo. And you say, okay, the psychiatric team comes in because, as I say, culture. Imagine the culture that we live in, being someone who's suffering, someone in pain, and now I have to fight. Or it's like, I don't want to spend that time disagreeing and arguing. It's like, I would just say, okay, I would just go along with it. And then it's to the point, the chaplain, I'm saying, okay, how would that look? Or how would that appear to her? Well, no, I think that you need to disagree with your husband. Keep fighting. It's just to the point that she's saying, I don't want to do this any longer. So the chaplain has to make peace with her decision. Not to say, okay, then let me now continue, because I'll be doing to her what she's saying. I don't want you to demoralize me. So that's a conscious decision that she made. So as a chaplain, I would have to join her in that decision. I may disagree with it, but I would be to join. And then if I'm struggling with that, that's where I would go and talk to my other peers about it and talk about but I would not share my struggle and even my discipline, how I feel about her decision.
And if I could say one thing about that too, and in addition to that, a chaplain is a member of the team, and we always talk about the team members using their resources. Well, chaplains also have resources, for example, palliative care. And the chaplain that I work with often will be in this situation and feel if she's not heard by the team, she'll come to us or come to other people that she knows will hear her, and the team may hear those people. So take it to another level.
I would also point out that for anybody in this situation who's being confided in, you just ask, do you want me to tell the team you're feeling this way? Or do you want me to just hold on to this? Do you want me to witness? And then you know what they're looking for from you.
I just want to add that, and I really appreciate that Ty and Chris and others are talking about this in terms of spirituality, because many times in patient relations we think that people think of our team here as religious rather than spiritual. And many people do, it was great that you just said this, they're worried that if you say, would you like us to call someone from spiritual services, they're thinking, oh, the end is near and I'm not aware. And so having that discussion to say, let someone come and help almost mine what it is you're thinking about, because everyone has this internal compass of who they are and what their world is and what their worldview is, and sometimes they don't know what terms to use to even describe it. So I think the folks in you're part of the team, spiritual care, really help navigate for the patient, and then provide almost like simultaneous interpreting services to the family and the medical team, because maybe the patient doesn't know what terms to use, and they're also just so tired from being ill, and they're just exhausted from the whole ordeal. So I think it's really important that, that members don't think of this as only for people who have a defined religious identity.
And one way I frame it is I initially start with, so I'm someone who's religious or spiritual. And from there I take it to, so what do you do when you're struggling? When you're going through a difficult time, what gives you strength? And from there I can take it to, I think we have people here, like our chaplains, who can help support you through that in a similar fashion.
So I serve on the baby ethics committee, and so the cases that I've been involved with before, in some ways, the information that's provided here would almost be a blessing, because a lot of the cases that we deal with, we don't know what the patient wants. They're either in advanced stage of dementia, or there's, they're in and out, with vicinity, or there's been inconsistent reports historically. So even with the trail of breadcrumbs that we might have what that person wanted, they could go to different directions. I guess in this situation, I'm thinking that, and this sort of gut check thing, so see what you think about this comment, is that I'm not sure if this is less hard or a different kind of hard as far as this case is concerned. I'd just like to hear what you think, just given what I've already sort of presented as a potential background, of there's actually information we have and we can work with. So is that something that really distinguishes this case from others that we don't know, or how would you characterize it?
That's a tough one to tease out.
I guess I'd say hard how. Hard and, it's not hard in that the patient's very clear, right? And she's within her rights. Hard emotionally in that I think we're all pretty primed for a different kind of case, and this does rearrange our thinking and force us to kind of rethink things. And hard because you're going to have to talk to the care team and explain to them that they now have a conflict that they're probably not used to, or they don't see very often. But I do think that, this probably, as it's written here, would not come before ethics. Right? She would say, no, I'll go along with it, and we'd never hear about it. Maybe, I don't know, maybe unfortunately. But I do think that there's a big challenge here for whoever ends up supporting this patient, because what I'm seeing, or one of the things I would interpret in this is that she cares very much about her family. Right? She doesn't want to be a burden on them, and she also doesn't want to go against them. So maybe what is most important to her is her family and how she supports them in her last days. So there's she has come to the conclusion that the way to do that is to not be a burden. But you may be able to help her see it differently. Right? What you can do for your family is help them prepare for your death. And that may take another round of chemo. They may need that additional time to have the right conversations with you so that they're ready. There's a great case write-up in the Journal of the American Geriatric Society from 2011 of a case at Bayview, 22 days and 2 blinks of an eye, about an elderly woman who came in with an advance directive that said, I don't want to be intubated, I don't want to be resuscitated, and her daughters were apoplectic. And seeing the suffering of her own daughters, she said, okay, fine, intubate me, put me on life support. And it was not because that's what she wanted, but it was because her biggest concern was supporting her family. And for 22 days, she gave them those days to come to terms with what was happening. And she saw that as her gift, so that by the end, they were ready. They were able to say, Mom, we understand. Do you want to come off the ventilator? And she said, yes. So, there may be ways to help this patient, see this next round of chemo as in accordance with what's most important to her, which could be supporting her family and preparing them. So, I think that's what's hard here, is finding how do we make this acceptable? How do we decrease her suffering? And it may not be that, there may be ways to decrease her suffering that don't involve foregoing another round of chemo. It may be psychological.
For me, it's just hard. and what I can say that what I have, all of the participants, all of the members of this case is my empathy, that I can connect, that it is challenging for anyone to talk about death and dying. And to know that it's difficult. Yes, the chaplains are here to explore those resolutions and those end-of-life issues. However, it's always difficult. It's always hard. It's always complex. And I'm aware that when I feel like, oh, it's not hard, I have to check myself. Because I may be minimizing someone's pain, someone's grief, someone's hope, so I'm cautious when I want us to go into trying to quantify.
I can make a quick comment here about just how difficult it is to go against one's family when their family has been really pushing towards, let's keep it moving, let's keep being aggressive, and making that decision as a patient sometimes comes as a very lonely endeavor. And there was a story I could share real briefly here about a colleague of mine that we actually did training together. And he had, as part of his training package, designed a way in which to write patients' prayers. So he would have a visit with a patient, ask them, we would sometimes conclude with prayer, and then ask before he left, would it be all right if I wrote that down? And 9 times out of 10, the patient said, sure, fine. And he'd go back to his computer, type up what he remembered as that patient's prayer, print it off, and bring it back to the patient. And that was part of his project. And I'd share that with you because there's one case in particular where, actually there's a number of cases, I think that this worked out really well. But one in particular was very similar to this case where a female patient was really struggling with how to tell her family that she couldn't do another round of chemo. And the family was just not going to have it. Even if it gives you 3 more months, we're going to keep going. And that was the message over and over. And she met with the chaplain and confided in the chaplain that this was it. And their prayer, her prayer was, help me, God, learn how to, and have the courage to share this decision that I'm making with my family and help them, my family, receive it. As he went back to his office, he worked on that prayer. He went up to her. She offered some edits. He went back, reprinted it, and at the point in time where all the family, she had called the whole family together, and she read her prayer to her family. And they were all obviously very emotional about it, but they all really respected and received her prayer, which was her decision to forego the next round of chemo. So it was a really powerful experience of actually helping, which in this case, I think part of the role of chaplain is helping the communication happen to the family and the ministry, in this case, to this woman's spouse. We have time maybe for 1 or 2 more questions.
So you had mentioned earlier that the chaplaincy serves across faith traditions. What happens with atheist patients in the hospital of faith tradition? Is there a role for the chaplain there? Can you engage with them around, or did that get covered by some other part of the hospital team? Or?
We have had atheist patients, I've had atheist students and colleagues. I look at as colleagues because I've engaged a person on their humanity. And I do not engage them or put them into a box or a category like you are not a spiritual being or someone that doesn't have a purpose. So I engage them on more like they're a human being. They're challenged by their suffering and their pain. So I'm very cautious. I'm aware of when I stay away from religious language. However, I'm not going to hide from them my identity that I'm here, to be here to navigate, to help you, to explore your emotion. It's all about the language we use, because anxiety is always high with anyone that's in a hospital. But it's like the chaplain goes in to try to diffuse those situations and engage and say, we're there here for you too. You are part of this world. You are part. We and I have different spiritual beliefs and values and morals. However, I look at the human being inside as someone that's hurting. This is someone here who's seeking healing.
So I'd also add that I do think this is a big challenge, that I did not know what chaplaincy was 7 years ago. And, when my family member made the decision to stop treatment, we were visited by chaplaincy. And spiritual beliefs in my family run from kind of lapsed agnostic to devout Orthodox atheist. And, we kind of went thanks but no thanks and didn't think twice about it. But, I wish we had. Talking to anybody who was willing to listen would have been therapeutic and helpful. We just simply didn't even know that chaplaincy was not denominational and would be open to that. So I do think that there's a serious education issue there that makes it challenging.
And I just end with a story. I got called by a hospice nurse family to come see a patient that was passing away. The family wanted me to come. They told me I should know that the husband was an atheist. The patient was an atheist. So I said, "Does he be there to come?" I said, "Yeah, he wants to come." Okay, I came, and I talked about baseball with him. We talked about the politics with him. And then I was about to leave, and he said to me, "Rabbi, say a prayer for me." I said, "I don't want to offend you in any way. You're an atheist." He said, "Yeah, Rabbi, but just in case."
So I want to thank our incredible panel today. And just to say a few words about how this topic aligns with ethics and ethical practice. Because in one way, you might be wondering, well, so what's the ethical issue here? I think there's a fundamental ethical issue that this panel has highlighted, and that's how we respect each other as diverse, complex human beings. That this case illustrates that autonomy is not always the answer. And respecting a person may, as our panelists pointed out, involve understanding their notion of what integrity looks like. So integrity is at stake for the patient, it's at stake for their family members, and importantly, it's also at stake for the clinicians. So interwoven in these cases are what we really care about: relieving suffering, promoting good, honoring people where they are. And I think that's the intersection where all of this comes together. When we think about William Osler's directive to us, and actually the founding of Johns Hopkins Hospital, in our charter it says that we are called to take care of the whole person. And if we are serious about that from an ethical point of view, then we have to consider what that means, and incorporating our spiritual dimension as whole people into the care that we're providing. So I want to thank everyone for their comments, and also to invite us to think about how we might create the environment where these kinds of conversations don't need to be a big event, but can become more commonplace out of our shared commitment to respect for the people that we take care of. So thank you for being here.